Good morning, everyone. Today, we'll explore how marketing research can be applied to sexual and reproductive health, or SRH. Unlike traditional marketing, which promotes products, healthcare research helps us understand patients' needs, uncover gaps in services, and design interventions that improve health outcomes. Think of marketing research as both a diagnostic and strategic tool. First, it helps us identify problems. Then, it guides decisions to develop solutions tailored to patient needs. Example: imagine a fertility clinic noticing high dropout rates in their IVF program. Research can reveal whether the leading causes are financial, emotional, or informational, which then informs strategies such as counseling, payment options, or educational resources. To make this lecture practical, we first need to outline what you should learn today, which brings us to our learning objectives. By the end of this session, you should achieve both core competencies and applied knowledge in SRH marketing research. Core competencies are: 1. Understand why marketing research is essential for SRH strategy and decision-making. Health systems often have limited resources. Research helps us allocate these resources effectively. For example, data showing low contraceptive uptake in a specific community can justify a targeted education campaign. 2. Learn the basics of healthcare market segmentation in reproductive health. Not all patients have the exact same needs. Adolescents, married couples, and women seeking fertility services require different communication strategies, service locations, and counseling approaches. 3. Differentiate between problem identification and problem-solving research. Problem identification asks, what is the problem and why is it happening? Problem-solving asks, what interventions are effective? Example: identifying why adolescents avoid contraception is problem identification. Testing a peer-led education program is problem solving. Applied knowledge. 1. Explain methods for collecting sensitive health data. Use anonymous surveys, private interviews, or peer group focus groups to encourage honest responses. 2. Recognize ethical and regulatory considerations. Ethical safeguards, like consent and confidentiality, are essential. Unethical research can harm participants and render results invalid. 3. Apply patient-centered approaches to redesign services. Example: adjusting clinic hours, introducing mobile clinics, or offering counseling services based on feedback improves accessibility and satisfaction. With objectives clear, we proceed to understanding the problems that marketing research aims to solve in SRH. Research begins by identifying the core challenges in SRH. Key problems. 1. Low contraceptive uptake. Barriers may include cultural beliefs, financial constraints, or misinformation. For example, some communities believe contraceptives cause permanent infertility. Simply providing free contraceptives will not increase usage unless these beliefs are addressed. IVF program dropouts. Fertility treatments can be emotionally and financially stressful. Couples may discontinue due to side effects, anxiety, or high costs. For example, research might reveal that lack of psychological support is a bigger factor than financial cost in dropout rates. Barriers to access. Patients may face geographical, social, or logistical barriers. For example, women in rural areas might avoid clinics due to fear of stigma if seen seeking reproductive services. Once problems are identified, we need to define clear research objectives that guide our investigation of these issues. Defining research objectives ensures your study focuses on actionable insights rather than vague questions. Steps are: define the why. Ask, what is causing the problem? For example, are IVF dropouts mainly due to cost, emotional stress, lack of counseling, or a combination of factors? Target audience. Segment participants for precise insights. For example, adolescents may require confidential sessions, while married couples may benefit from joint counseling. Service gap analysis. Examine whether current services meet patient needs. For example, clinics may operate 9 a.m. to 5 p.m., but this may not suit working women. With objectives set, the next step is collecting data, the evidence that will answer our research questions. Research draws from two main data sources: secondary data, definition, existing information from previous studies or records. Examples, national health surveys, hospital records, published research. Advantages, quick and cost-effective. Limitations, may not answer specific questions for your target population. Primary data. Definition, new data collected specifically for the study. Examples, patient interviews, focus groups, post-visit satisfaction surveys, mystery client visits. Advantages, directly addresses your research questions. Limitations, time-consuming and sometimes expensive. After selecting your data source, we need to determine methods that capture nuanced insights, particularly for sensitive topics. Numbers tell what is happening, but qualitative research explains why. Methods are focus group discussions. Small, segmented groups encourage open sharing. For example, adolescents discussing contraception are more likely to speak honestly in peer-only groups. Ethnography, to observe patient-staff interactions to identify subtle barriers. For example, staff may unintentionally discourage questions by rushing consultations. In-depth interviews, to explore sensitive topics like infertility stress, abortion stigma, or STI experiences. Transition, even well-designed studies face biases, which we must identify and mitigate. Biases can compromise research validity. For example, social desirability bias. Participants report socially acceptable behaviors rather than reality. For example, over-reporting condom use to appear responsible. Gender dynamics. Cultural norms may prevent women or men from speaking freely in mixed-gender settings. Stigma bias. Fear of judgment may lead to underreporting sensitive behaviors such as abortion seeking or infertility struggles. With biases in mind, we complement qualitative insights with quantitative analysis to identify patterns and trends. Quantitative data helps us map usage patterns and identify areas for improvement. Example, contraceptive method mix chart. Oral contraceptives, injectables, long-acting reversible methods like IUDs, implants, traditional methods. Insight, if long-acting methods are underused, this might indicate a need for education campaigns, staff training, or stock adjustments. Once we have gained insights, the next step is to use them to redesign services. Research only matters if it informs action. 1. Access barriers. Problem, rural women cannot travel to distant clinics. Solution, mobile clinics bring services directly to communities. Financial barriers in IVF. Problem, high dropout rates due to cost. Solution, flexible payment schemes or counseling support to improve retention. Key point, research identifies problems, analysis interprets them, and interventions close the gap. This is the essence of patient-centered service redesign. All interventions must also respect ethical standards to protect participants. Ethics ensures research benefits participants without causing harm. 1. Informed consent. Participants must understand the study, potential risks, benefits, and the right to withdraw. 2. Confidentiality. Personal data must be anonymized to prevent social or legal consequences. Importance: ethical research builds trust, credibility, and meaningful impact in SRH programs. Finally, let's reflect on how these research principles apply in real-life contexts. Marketing research in SRH is not just about numbers. It's about understanding human experiences and translating insights into actionable improvements. Discussion prompts: have you seen examples where research influenced SRH service delivery? How could mobile clinics, peer education, or counseling programs improve SRH outcomes in your community?